So I picked out this is probably the subject closest to my heart. So I started studying self-injury nearly 30 years ago, and have a distinct memory of coming as a graduate from university, working for my first year in a hospital in the UK. And there I met 2 or 3 people with Cornelia de Langes syndrome, didn't know it at the time, of course, who showed the most severe self-injury. And despite the efforts of very dedicated team, nursing team, speech and language therapy, physio, OT, psychiatry, psychology, so on, we're unable to touch this behaviour. And I think then, after my clinical training, I was really pleased to be able to do a PhD on this. And that's where I started to meet more and more people with Cornelia de Langes syndrome, then with Lesch-Nyhan syndrome, Smith-Magenis, and so on. Again, I didn't know it at the time, didn't have the diagnosis. And so that pathway really from trying to understand self-injurious behaviour in all people with an intellectual disability, it led very rapidly to the syndromes. And the reason for that is that within each syndrome, you can build a model of the self-injury which explains more of the variance and so gives you better clinical targets than if you take a large heterogeneous group of people. So I just want to now take a bit of a step back and speak a bit about the causes of self-injury and some of the interventions. So our website has a lot of information on self-injury and there are a lot of publications on ResearchGate. So I'm just going to make some arguments about what we don't understand and what's interesting, I guess, in this area, and then say a bit about what I think we do understand. I think the issue is increasingly one of the right intervention for the right people, as opposed to having to devise new interventions. It's about access, availability, and delivery, and not about the new interventions that we might see. The literature in the last 30 years has been dominated by an applied behaviour analytic perspective, and I'm contributed to that literature, and in saying that I feel that literature's been too dominant, I do not mean to imply it isn't helpful. There is no doubt that it's given us methods, techniques that have been incredibly helpful in self-injurious behaviour. There's a large body of literature, no doubt about that. But I think we should not assume that it is always applicable, nor that it is immediately applicable in the same way for all people. And this is where we come back to the notion of phenotype-environment interactions and their importance in understanding some of these behaviours. So let me just start by talking a bit about prevalence and form, some of the things that we need to know in terms of targeting those at risk, but also those facts that will challenge an exclusively operant learning or applied behaviour analytic perspective. And these data do exactly that. So you are looking at the prevalence of self-injury in a number of different syndromes. On the left is a heterogeneous intellectual disability group, and of course this is made up of people with many different causes of intellectual disability. And the prevalence of self-injury in there, importantly, is slightly higher than we would expect normally. The figures in intellectual disability range from about 4 to 20%, a little bit age dependent. But as you run your eye across the syndromes, Angelman's, Cri-du-Chat, Cornelia de Langes, Fragile X, Prader-Willi, Lowe, Smith-Magenis, you will see that they are nearly all higher than the heterogeneous group. In other words, there is elevated risk, and for each group that is significantly higher, statistically significantly higher, except for the Angelman syndrome group. And that's really interesting, because if you look in the intellectual disability literature, the risk markers for self-injury are greater degree of intellectual disability and expressive language impairment. Angelman syndrome, both of those features are very, very prominent, and yet their level of self-injury is probably half what it should be given those risk factors. When we ask the question, why are people showing self-injury, we should also ask the question, why don't people show self-injury when they have those risk markers? What is it in Angelman syndrome that protects against self-injury? that is not there in other syndromes? That's an interesting question. But I put on there, and we've published these figures now in a paper on self-injury I'll mention at the end. But this shows that in, for example, Cornelia de Langes syndrome, you are 6.5 times more likely to show self-injury than if you don't have Cornelia de Langes syndrome. So that's a kind of immediate elevated relative risk. If you then take physical aggression, the first thing to notice is the profile is different than that for self-injury. And this tells us something from a clinical and research point of view. And this is that terms like challenging behaviour are sometimes unhelpful. I do know why that term was used, but I'm increasingly feeling in research that we should not be using the term challenging behaviour. It is too imprecise. And here's the reason, is that self-injury is significantly elevated in Cornelia de Langes syndrome, but aggression is not. But aggression is significantly elevated in Angelman's, and self-injury is not. If we'd have lumped those two behaviours together, using the term challenging behaviour, we would not know about the specificity, and we would then not seek different causes. So I think we need to be much more careful about the use of the term challenging behaviour. These behaviours segregate across syndromes. Let me just say something about form. I know this is a busy table, but it's sort of intuitively fairly straightforward. So these are the different syndromes. These are different types of self-injury. If the number is lit, if you like, in white, it shows you that that form of self-injury is much higher in that syndrome than we would expect by chance, and you can see an odds ratio in there. So simply when you look at Smith-Magenis syndrome, you see a diverse range of forms of behaviour that occur more by chance than we'd expect. The point here, as well as for the difference in self-injury across syndromes, is this. If applied behaviour analysis or a learning theory or environmental explanation was complete, we would not see differences between syndromes either in prevalence or in form. It would be flat, but it's not. The environmental differences would be randomly distributed across the groups. There might be some differences, but generally we'd expect these to be flat, but it's not. So in Prader-Willi syndrome, you do not see all of the forms of self-injury. You see high levels of skin picking, predominantly arms and legs. In Fragile X syndrome, again, many of the forms are not elevated, but biting is, and it's typically to the back of the hand, just above the wrist. So again, that's a really highly specific form, and from an operant learning point of view, we wouldn't expect one form to be dominant. Cri-du-Chat syndrome, this is hair pulling, very, very common in that syndrome. Scratching, again, Cornelia de Langes, hitting self and pulling hair. So the reason for making this argument is simply to say operant learning theory, I think, would struggle to explain why specific forms of these behaviours are associated with specific syndromes. I also have no idea about why this is. We can think about some of the reasons, but I think we're not very far ahead in being able to explain these differences, but they're important. Okay, I realise I've done 3 talks already and I've spoken in every one about pain and discomfort, but it's very, very important. I think we're missing this. So even in children of typical development, so our first thing clinically we look for meeting someone who self-injures is this child in pain and discomfort? Is there pain and discomfort? In typically developing children between the age of 1 and 4, about 15%, 1 in 8 will show self-injury, head banging, usually at night, and half of those will have a middle ear infection. So this is true in typical development. Again, I'll mention Cornelia de Langes because this is where we started to explore the pain argument, and it is this gastroesophageal reflux that I mentioned previously that is really prominent in this syndrome. So again, these are the health conditions. I've made this point already, but I think one of the things that I learned as we saw more and more people with Cornelia de Langes syndrome was the association of the middle ear infections, the dental problems and so on. And I didn't realise these were downstream from the GI disorders and the importance of dealing with those. And the reflux in Cornelia de Langes, I may be seeing this everywhere, but I'm pretty convinced that we do see this in a number of other syndromes. And this is easily treatable. Well, not easily treatable, it is treatable. Part of the problem is simply convincing GI specialists that this is something that should be looked at and should be aggressively treated. I'll just show you a case study. So we went to see this girl back in 2007. We were recording her behaviour across different environmental conditions. She's showing self-injury. She's pulling her hair about 10% of the time. That's, well over an hour a day. She was on paracetamol. One of the problems is, for her size, she was on a very high dose of omeprazole. That's not unusual in Cornelia de Langes syndrome. The parents had run out of medication, and then they had to go and see their general practitioner, their physician. And the physician said, that's a very high dose of omeprazole. The parents said, yes, it's a very high dose of omeprazole. And I won't prescribe it until I've checked with a GI specialist. So she was without her medication. And then in the interim, they got the medication reinstated, but she also had emergency dental treatment, and she had 2 temporary fillings fitted. And we went back to see her only just over a week later, and again we recorded the levels of her self-injury, and there was a very significant change in her behaviour. She was now on omeprazole. She was still showing some self-injury. It hadn't completely gone away, but she was very different. She was a profoundly disabled little girl. She had no speech. And when I first met her, her head was down, and she wouldn't engage in any eye contact, and her head was down, and she was mainly hair pulling. When I went back to see her again, and she was on the omeprazole, her teeth had been fixed, now her head was up, and she was looking at me. And just to go back to the autism argument, these were these are different children. The social behaviour had dropped away. Her whole behaviour had changed. The message for me was it wasn't just about self-injury. It was about all of her behavioural demeanour that had changed. The other thing that was really telling about this was the parents said to me, as soon as I arrived, she is in pain. They knew she is in pain. They knew her pain signature. But they said, when we go and tell the physician this, the physician says, no, you often see these behaviours in children with Cornelia de Langes syndrome. And that's the point. Yes, you do see them in Cornelia de Langes syndrome, but they're caused by pain, which is coming from a physical condition that you see in Cornelia de Langes syndrome. And that's the argument we have to make. So when we make, as researchers, the argument, these are behaviours you see in this syndrome, we also must not say that doesn't mean that you cannot change them. You can. And so it's an important lesson for me in how we gave information. How does this work? So if someone this little girl was self-injuring and she was having pain here, one of the ways in which this may work is by pain gating. So we know that if you have chronic pain or sharp pain, the signal is carried along C and A delta fibers, but you can shut this gate by stimulating different A beta fibers. So the best example is when you bang your head and your mum says, rub it better. What you're actually doing is stimulating A beta fibers that then gate the pain. They stop the pain. So we think what the children are doing is gating the pain that's here by pulling their hair. They're stimulating A beta fibers. And the important thing here, I think, is the clinical message is that the site of the self-injury is not necessarily where the pain is the cause of the pain. It may be elsewhere. And that seems to me very, very important. Just to pursue the Cornelia de Langes argument, I mentioned earlier on that we measured peripheral nerve speed, and it was decreased in Cornelia de Langes. And one of the points there may be this, that if you are trying to gate the pain and the peripheral nerve speed is slow, then it may be that you have to push at the gate harder in order to gate the pain. And if you push at the gate harder by pulling your hair harder, by slapping harder or scratching, then you may cause another injury, and then you go round again. And so that tells you about the importance of this early intervention for painful conditions. So I've shown this already, but I just want to pursue this because when we learned that lesson, we started to go to other groups and we asked the question in different ways to make sure we were getting this right. So we went into classrooms with about 40 children, numerous different syndromes, and we divided them up into children who were showing challenging behaviours. So here we are using the term. We said any behavioural difficulty versus none. 2 groups. We then said, in the children who are showing challenging behaviour, do you show higher FLAC scores? So FLAC stands for face, legs, activity, consolability, crying. I'll come back to that. But it's a way of scaling pain behaviours. And what we found is the children who had challenging behaviour showed more pain behaviours than the other group. Now, it may be some of those behaviours are challenging behaviours, but it seems very unlikely. Facial expression, for example, crying, it seems unlikely. So even in a group of children with heterogeneous cause of intellectual disability, those children self-injuring were showing more pain behaviours. You could also argue because you self-injure, you cause yourself pain, and that may be correct. But some of the health conditions, that doesn't appear to be the case. The reflux, middle ear infection. So we then go to a group, I mentioned this already, in tuberous sclerosis complex, we find the same relationship. But what this taught us was we should, in each syndrome, know the health conditions, make sure they're screened for, and make sure they're treated appropriately very early on, because that would prevent the self-injury in the first place. That seems to me very important. This is in autism spectrum disorder, so we just took children and adults with autism spectrum disorder, and then we said, what's the relative risk of self-injury given you've got a health problem? So we looked at the children and the adults with health problems, broad-ranging health problems, and again, we found the risk of self-injury is higher in children with autism who have health problems than not. Now, the health problems were middle ear infections, sinus infections, skin disorders, and GI problems again, gastrointestinal disorders. And again, there may be an argument about causal direction, but we're finding this association in many, many groups. So I hope I've convinced you of that. I'll stop now. But one of the measures that we use is called the FLAC. So it's an acronym for face, legs, activity, crying, consolability. On the Cerebra website, there is a chart that Cerebra have developed for parents, and many parents have asked for this to be pinned on their child's classroom wall, and it allows you to look at some of the possible signs of pain, a teacher to see those. And if the parent's able to describe the child's pain signature, because it differs across children, then there's a quick checklist to be able to do this. The other thing we've advised parents to do is to get a quick video of the child's pain signature when they know the child is in pain, when they know there's pain-associated self-injury. Being able to show a quick video of that to a physician is actually very helpful. And if we're seeing children clinically, then I would like to see a quick video of the episode. And the other things to look for, I think, is when parents say the self-injury just comes out of the blue. I didn't see it coming. Most parents will spot a trigger for challenging, difficult behaviour. Most parents know. 9 times out of 10, they'll get it, and they'll get it right. But this, they will often say, it just came out of the blue. It started, and then they'll also say consolability. There was nothing I could do to stop that. And then it stopped, and it went away. Then it came back. We call this burst-run behaviour. But this kind of pattern of starting out of the blue, stopping regardless of what you're doing, period, starting up again, I don't have evidence for that, but when I speak to parents, they describe that. We should know I could show you in Smith-Magenis syndrome, I don't have time to show you video, but we certainly videoed children quite young. One of the behaviours you see in Smith-Magenis is complete nail removal. And it's very unusual, both toes and fingers, and removing the whole nail. And we've certainly videoed children. And what you will suddenly see, the video of a child sitting in a wheelchair, and suddenly the child sitting there and suddenly grimaces, and grabs his toes and turns around and he's rubbing them. And I think there is some evidence of a peripheral sensory neuropathy in Smith-Magenis. And it may be that at the extremities, the children are experiencing a tingling or burning sensation that you sometimes have with peripheral sensory neuropathy, and that they are then trying to remove that source of pain at that point. And if there's a delayed pain response, then actually removing the nails, there may be no immediate negative feedback. But I just mentioned some of these. In Angelman syndrome, we've occasionally seen people between around the age of 9, 10 through to 15, 16, where people report significant behavioural change. And at that time, we do wonder about reflux, especially if there's scoliosis developing. And we wonder whether the children are experiencing pain and discomfort around that time. And again, that's slightly unexpected because it's got a later onset than you'd normally expect. Okay, so I've mentioned pain. One of the important things is this is how the behaviour might get started in the first instance. But once it's started, there is no reason that a learning process can't take over. And if we've ruled out pain, this is where we go next. And so once a behaviour has started, it can gain a function. So this is the applied behaviour analysis interpretation, an operant learning interpretation. And the behaviour can function to say a number of things. And in this respect, it's no different from aggression or tipping over furniture or screaming, for example. And I'll just show, I find this very helpful to talk this through with parents about what happens, because it often feels as if one is blaming the parent for the way they've responded to the behaviour and led to it keeping going in the future. But there's a very natural process that's tied almost with very good parenting that leads to this. So people see self-injury or a challenging behaviour. People find it aversive. Of course parents do, to see your own child bang his head. I think that's very difficult for parents who be frustrated, anxious, confused and distressed, and it leads them to act. It's what any good parent does when they see something like that. And then when they act, they engage with the child. And you talk to parents and they'll say, I comfort him, I reprimand him, I tell him to stop, I offer him things to distract him, and so on. They go through a whole list of things, but we know that those things can be rewards. They can be things that the child finds reinforcing. That makes the behaviour more likely to occur in the future. And then the next time the child has that need for others to do or give something, the behaviour happens again. People find it aversive, and so we go round. And I think this is, whenever I describe this to parents, they recognise that happening. They can recognise their immediate response. And this won't translate well into Norwegian, but we give them a rhyme which says, 1, 2, what should I do? And all it does is help them pause when they see a behaviour and ask the question, if I do that now, will I reward that behaviour? They've, of course, got to make the child safe and protect the child, but there are ways of doing that without it being rewarding. The other thing we talk through with parents is this, that we've described this bit of the trap, but it's what happens here that's equally important. So when a reward for the behaviour is presented, the behaviour stops, the self-injury stops. The reason it stops is that need in the child has gone away because something's been presented. And when it stops, that's a reward for the parent. There's nothing better for a parent than when their child stops self-injuring. And so that makes it more likely that the parent will use the same strategy in the future. That makes it more likely they'll reward the behaviour, and then the challenging behaviour will occur, come down, and then we'll go round again. And again, when you describe this to people, they can see how that's worked over time. But it's very important, I think, to sort of describe that in a way that recognises that this is a very natural interplay. It's a very natural exchange that happens, and that nobody is saying there is then blame for why the child has learned to show that behaviour. For a note, and I do think this is important, this is a slightly different type of reinforcement, but it's where a child may want something to stop, and that will lead to negative reinforcement. The thing terminates. So you're asking a child to dress in the morning, self-injury, say, okay, we'll take 5 minutes and come back to it. That, again, is a kind of reward. The important point in both of these is this, that I mentioned before that in Smith-Magenis syndrome, for example, there is that incredibly strong drive to be with a particular adult. And the same in Angelman syndrome, a strong drive for attention. So what may happen here is that this reward in those two syndromes is incredibly potent. It's much stronger than for another child because of that drive to be with that parent, or because in Angelman syndrome, that drive for eye contact. The reward here is incredibly powerful. And similarly here, and we've shown this in children with autism, that the trigger might be something about the phenotype of autism. So it may be something like an interruption to a ritual, an interruption to a routine that's the trigger, and the reward is the routine being reinstated. So there may be, although the trap may operate, there may be interactions with the phenotype that are quite important to take into account. We know this from the literature, but there is very good evidence that effective functional communication training is really very important. And it may not matter what the form of that is. It may not matter how the child is able to communicate. It may be pressing a Big Mac, it may be PECs, it may be signs, Macathon. But it is important that the child can say, I want this and I don't want that. That's very important. And when you look at some of the physical characteristics we spoke of, where poor hearing might predispose to poor expressive language, you can see that children with Smith-Magenis and Cornelia de Langes have gained another risk factor because of that physical characteristic. Then they have poor communication, then the behaviour functions as communication. So this effective communication system is really critical early on. Just want to finish the self-injury on something that we felt for a while it's very troublesome, very difficult clinically, and we feel it's related to behaviour dysregulation. So you may, if you work with people showing the most severe self-injury, you may come across this problem where people have a preference for restraint, either imposed by other people or that they seek out themselves. So in these images, at the top, you see a young woman holding her arm out for a splint to be put on, and a young man holding his arm out for the splint to be put on. And here, this young woman has trapped her arms behind her back. This young man is sitting on his hand. This young woman was in a social education centre in southeast London when I was a clinician there. And she'd gone to the social education centre, and they said the policy of our local council is that we cannot use restraints. We cannot use the straight arm splints that she depended on for her self-injury, and they took them off her. And she went in and spent 1 or 2 days in real distress, punching her head repeatedly until she found these objects that she put on her arms in order to control her self-injury. Other people, this young boy had 3 different forms of self-restraint. And this young woman doesn't look like self-restraint, but she's holding it. She will always have her hands pinned behind her back or on the floor, and some similar forms here. Now, the point of this is, let's say the operant learning theory can account for all self-injury. That would mean the behaviour is voluntary, and I show it because there is a reward that comes from that. If the behaviour is voluntary, and I can show it because there's a reward, or I cannot show it, then why do I need to tie my hands up? Why do I sit on my hands? Why do I need that restraint? And people say, well, the reason you need that is because the behaviour is painful. Well, if the behaviour is painful, then why doesn't it reduce? Because there's a natural painful contingency that isn't enough to outweigh the reward. So it's hard, I think, to explain these behaviours from an operant learning point of view. What's interesting in when you see these behaviours, this is in 200 people with autism, is that these two, impulsivity in particular, and high-frequency repetitive ritualistic behaviour, are associated with that self-restraint when self-injury is also present. And what's interesting there is both of those behaviours, repetitive behaviour and impulsivity, are associated with impairments of executive function, of inhibition in particular. So one theory that we have is that in people who have impaired inhibition, unable to stop a behaviour starting under a given stimulus condition, or stopping a behaviour once it's started, those are explanations about repetitive behaviour in autism and impulsivity in ADHD. Those people who have those problems, once they start to show self-injury, then they're unable to inhibit the behaviour because there's an executive function problem. So it's speculative, but there's a number of studies now showing that impulsivity is associated with self-injury in different populations. For example, in people with autism, high functioning, people with autism. So our model may now be something about, this is the operant model, it's an antecedent, behaviour, cost and benefit. Note here that cost might be minimised in some syndromes like Smith-Magenis with heightened pain sensitivity. So that the benefit outweighs the cost when you don't feel the pain as much. That's arguable in Prader-Willi as well and one or two other syndromes. But here is the EF problem, evidenced by impulsivity, poor interruption, an EF problem evidenced by repetitive behaviour. And that leads to a kind of disinhibition. And consequently, people are unable to control their behaviour. Consequently, they need external control. So that's very speculative. But one of the things it tells us, and I'll come back to this, is that impulsivity and repetitive behaviour are risk markers for the development of self-injury. We've just shown this in a study in the UK. But importantly, they are risk markers for the development of very severe self-injury. And what that means is that, when I spoke about risk markers before, is that if we have children with Cornelia de Langes, autism, any intellectual disability, who are young and have behaviours like impulsivity and repetitive behaviour, they might be at higher risk for severe self-injury in the future, and maybe we should target them. I'll just finish by showing you, if that problem develops, there are still behavioural strategies. So this is the young woman I showed you here. She'd found a piece of wood to put on her arm to control her movement. We introduced a splint, and in this splint, you can, it looks horrible, I know, but you can adjust the amount of flexion by moving screws around. So we start off with only a little bit of flexion, and the self-injury remains at 0. We then increase the amount of flexion, and it's still at 0. And then we increase it to the point where she's able to enjoy a cup of tea, so clearly she could punch her face, but it remains at 0. Over a time, we were able to remove this upper section completely. We left the bottom section intact, and we then cut the bottom section until it was about this big. And then it was on each arm, it goes under her jumper, it looks like a bangle, and it keeps control. Interestingly, if you remove that small 2-inch bangle, she will immediately punch her head, you replace it, and it stops. You've got to know what that bangle does, and don't ever touch it. And you reach a point, I think, where you say, that's it, we'll stop there. And you always keep a spare pair of splints, by the way. Don't get the scissors out or the saw without having a spare pair. So I'll finish there, really, by just saying again, one of the important things, so I mentioned the FLAC and the non-communicating child pain checklist for pain identification. Often, we find ourselves in the role of, as a psychologist, it's very difficult because we are speaking to our colleagues in medicine saying, we think there's a painful health condition. And we're psychologists, we don't know anything about physical health conditions. But with respect, we'd suggest that there is a painful health condition. And there's sometimes a very difficult debate to be had there. But the parents often need advocacy and support to find that. You'll know of functional analysis. A lot of this is on our website. We've used this in the syndromes to look at aggression in Angelman's, as I mentioned. And then the kind of regular interventions. So the point I make is not that in the genetic syndromes we need new interventions. We just need to be doing the right thing at the right time for the right people. And if we can get that right, then I think we can make quite a dent. I'll finish on early intervention because I think it's so important. I've mentioned risk markers a number of times. We could go to schools, or we could take a group of 100 children with severe intellectual disability, for example, and we could calculate, we can work out their risk markers, calculate their risk that they will develop more severe self-injury. And the point is this, that when we meet children initially, there's a little bit of head banging, there's a bit of hair pulling. It's not much. We don't identify it as a problem. But soon it becomes a problem where people say we need to manage that behaviour, it needs intervention, we need resources, we need external help. And then often in the UK, we need specialist placement. We actually can't cope anymore. And the question is, what's the impact on the person, their families and their carers as severity increases? And if we must make the argument about health economics, it's an argument I find unpalatable, but if you must make the argument, then it is a lot cheaper to intervene here than when you are paying, as we've seen, £150,000 a year for a specialist service up here. We only need to shift this curve to the left a couple of years to make huge financial savings if we want to make a health economics argument. The humanitarian argument, for me, is sufficient. And these are the risk markers. I've shown them before. I'll show you the paper in a second, but we've tried to quantify these. So you can imagine an intervention for the under fives. We look at the under fives. We quantify their risk. We make sure they're seeing someone for their health conditions. If self-injury emerges, we make sure they have functional communication training. We can start to reduce the chance of self-injury, or at least shift that curve along to the right. And I don't think that would be resource heavy for the under fives. That could be delivered within a school setting, for example. It doesn't necessarily need huge specialist intervention. This is where we've made the argument about early intervention. This is published online, but is downloadable from ResearchGate. And in the last few paragraphs, we've tried to push the early intervention argument as strongly as we can and support with evidence. So I managed to come in 5 minutes before 12, never get between people and their lunch. And there's all of these resources available to you, or email me, particularly if you're interested in early intervention. I'd really love to hear from you. Thank you for your attention throughout the morning. Sorry it's been me for 3 45-minute sessions. And I'll stop there by thanking my team back at Birmingham University.